Thanks very much for the opportunity to talk today. My name's Pebs. I'm a medical oncology trainee. So I work at, my training's been at the Royal Marsden, and at the moment I'm doing my PhD at St Mark's with Kevin Monaghan. I've been here the past couple of years as part of Kevin's entourage, but this is the first time I'm talking. So I'm really excited to speak to you guys today. So I'm going to cover two things within my talk. Firstly, what happens when you're diagnosed with a bowel cancer and just the kind of pathway to that. And then the part two is a bit more about my research, and that's why Lynch syndrome is different. So bowel cancer, as many of you may know, is cancer that is formed in the large intestine. And this is a drawing done by myself. And within this talk, there will be some AI-generated images and some drawn by me, so you can see if you can work out which is which. And so it's a cancer that affects either the colon or the rectum. So what happens? So if you have symptoms of bowel cancer, so something like abdominal pain, you have abnormal bleeding from your back passage or any of these things, you might seek help from your GP. And this is within the general population, not just people with Lynch syndrome. Or you might go for routine screening, again, either in the Lynch syndrome cohort or in the general population. And then you may go and have a colonoscopy. And then you have this conversation of, we think this could be cancer, which is obviously a terrifying moment for many people. And I think the expectation is that from that conversation, you go immediately into a treatment plan and a discussion about prognosis and what this means for you as an individual. But actually, those people who've been through that will know that it's actually a lot of other things go on in that space. And so I guess I wanted to talk today about the different things that happened during that time, because this is a really difficult time for patients. And I see them at the end of this point, and they're grateful to get the treatment plan at that point, but there's a lot of things that go on in between. So I'm going to talk to you a bit about what happens behind the scenes after that conversation, perhaps in endoscopy, if we've seen something and we think it could be a cancer. So usually at that time point, there's a biopsy taken and different scans, and then this MDT meeting that I'm going to go through. So the biopsy is a small sample of the tumor that's taken usually during colonoscopy, but can be through other methods. Sometimes you can't access things at the time of colonoscopy, and there needs to be other ways of accessing some material. And one of the things that we do is we take this really, really tiny sample and look at it under a microscope to try and understand what is there. And does it look like it's come from the bowel? Does it even look like a cancer? Does it look like an infection? It could be many different things. And then if we identify that it looks like it could be a cancer through different steps, then we also look, certainly in the UK, for Lynch-related features. And then the scans that you might have after this time of we think you might have cancer is a CT scan that looks at the whole body, and that's mainly looking to see if there's any evidence of cancer elsewhere in the body. And that's really important to know because it informs how we treat a person as an individual. And you also might have an MRI scan, which is more of a detailed view, and that's especially relevant in rectal cancers. You might have other scans as well, and this is an individualized process to an extent, so there may be other things that come at this point as well. And then we have this thing called an MDT meeting, which is a multidisciplinary team meeting. And this is probably the most important part of the whole thing, because you take all of the results from the biopsy and from the scans, and each person that's involved in this discussion has a different perspective. And so that might be a surgeon, oncologist, geneticist, specialist nurse. They all have their own viewpoint, and it's really important that each of those people are there because they shine a different light on the individual going through the cancer diagnosis to help develop a treatment plan for that person. So there are lots of different treatment options, and these would be discussed with you as an individual at the time, but largely these are surgery, which may remove the cancer, but also surgery can be done to bypass the cancer. If you have a cancer in your bowel that is blocking the passage of stool, sometimes it's not possible to remove it at that time, and so you may have something to bypass that, and that would be with a colostomy stoma bag. The other things include chemotherapy, and there are lots of different types of chemotherapy, and that generally sort of the process by which that works is to try and kill cancer cells. Radiotherapy can be also used, which is more of a targeted treatment directed to a particular area. And then immunotherapy, that's one of the really important things that's been used over the past decade or so, is treatment that helps your own immune system fight the cancer. And there's also options of no treatment and symptom control only. So the other important considerations that I think can sometimes feel very overwhelming in that first consultation when you're talking about all of the treatment are of fertility. So people that are diagnosed with cancer may or may not have completed their family, especially within a population of people who have Lynch syndrome, who often develop cancer at a younger age. So this is something that's really important to be discussed with your oncologist before starting any treatment, or with your surgeon, or any treatment that might be involved. So if that's not brought up, please do bring that up. Other impacts and things to consider are the impacts on your finances if you're still working at the time of a cancer diagnosis, and also how this might impact your career if you need to take interruptions from work. Also the people that are around you who might be supporting you, and also the people that generally rely on you to support them, like children or elderly relatives. And again, we've already heard from Terry and Fiona about the importance of genetics and family history, and these are things that are also really important for us as clinicians to bring up, but also if you've noticed that that's not been brought up, please do. So that's a sort of whistle-stop tour about diagnosis of bowel cancer. And now I'm going to talk a little bit more about my research that I've been doing for the past 3 years of my PhD. So we know that with Lynch syndrome, patients have a higher lifetime risk of cancer, but we also know that their immune system is more active. And the cancers often respond better to immunotherapy, and that having regular checks, screening, surveillance helps us to catch cancers early, or pre-cancers. But cancers can still develop between the checks. So it's really important to, if you have new symptoms, even if you've had your colonoscopy a year ago, to please still seek help. So this is an analogy that I use to describe Lynch syndrome to anyone who asks me about it, which is generally my friends and family. And since I've been doing this PhD, I've tried to come up with an analogy that is suitable for people to understand. So I've got this idea of the bouncers, which are the two mismatch repair genes that you have. And then the security is our immune system. So bear with me while I go through this in a bit more detail. So the bouncers act as a mismatch repair. And so they are checking the ID of each cell as it comes through to see if there's any errors within the DNA that's been replicated from the previous cell. So they are going through and checking each cell's ID, and that's these are my drawings, obviously. And then if they notice an error by the dodgy smile on that cell, then they are able to repair it. And this has been shown in more scientific detail by the previous speakers. And patients with Lynch syndrome, they only have one bouncer. So this is something inherited from your parents. There's different numbers, but it affects around 1 in 300 people. So if you're healthy and you lose one of these bouncers through a random loss, then it's okay because you still have the other one. But if you have Lynch syndrome, you only have kind of one chance to lose that other bouncer. So if you have one bouncer, they can still operate effectively. And that's why people are able to, repair their DNA, even though they only have one functioning copy. But if that other bouncer goes off, then the cells can come into the club without anyone checking their ID. So this is where the security comes in. So this is the security inside the club, and that is our immune system. So our immune system is incredible because the specific part of the immune system I've been learning about is our T cells. And there are this vast number of possible T cells, T cell receptors, which is the bit that might bind with something foreign that it is exposed to. And this number, 10 to the 15, 10 to 16, is pretty huge. So I've thought of this way to try and explain to you how large this is. So if the number of words spoken per day on average by a human is 16,000 words per day per person, it's slightly more for women and slightly less for men. And our global population currently is around 8 billion people. So if you think of all the number of words of all of the people in the world, if we imagine the population rates just stay static, it would take 214 years to get to the number of words that reflects the number of different possible T cell receptors that we might have in our body. So that is incredible and vast. And it's, something that's quite difficult to, get your head around. But it means that each of our immune systems, because we have all these different options of T cell receptors, are unique. So this, again, back to the security inside the club, is our immune system. And how it works is it can recognize these abnormal cells by what's presented on the surface of them. So, and it can say, you can't be here, get out. But what it also does is it recognizes things that are part of our own body, so our self. So it doesn't attack itself the whole time. So, but the other thing that it does that's very clever is if it's seen that same abnormal cell before, then it's got all of its mates ready and being like, you are out of here, but at a much faster rate. So that is here. I've seen you before, get out. So what can we learn from the immune system? And this has formed the basis of my entire PhD. So instead of looking particularly at the cancers or the pre-cancers, what I've focused on is what is the response in individuals to those cancers. So people who don't have Lynch syndrome might have these different amounts of T cells around. They might have been responding to vaccines they've had, infections, and they're generally a diverse population of these different immune cells ready to manage something. But in people with Lynch syndrome, because they are constantly needing to deal with these abnormal cells that come up all of the time, they have the clusters of immune cells that are able to respond to these abnormal cells and manage them for them. And this is the premise by which lots of vaccines work, and I will hear a bit more from David about vaccines later. But we can also see in Lynch syndrome is when people have cancer, there is evidence of more of these immune cells that are responding to this mutated cancer at the time. And so this is something that I've been obviously thinking about a lot. And one of the proposals that we have next, and I'd be grateful for anyone's thoughts in general, and come and find me in coffee or at lunch, but is whether we can use these blood tests, which identify different changes in our immune system, to understand whether people who have Lynch syndrome, whether they have evidence of cancer in their body or not. And I think, based on the preliminary results that I have, that we can use this as an adjunct. And this wouldn't be necessarily replacing all of the things that we have already, but it might be something that we can use alongside to identify people who might not need to have a colonoscopy, or might need to have an additional colonoscopy, or find a cancer in between times. So that's one of the things that I'm thinking about trying to do, and I've applied for some money to try and do. And the other thing as part of that would be trying to do this blood test, but with, I don't know if anyone's seen these very, very clever clip onto the arm tests that just take a tiny bit of blood and it doesn't really hurt and you don't have to go to hospital. So that's one of the other things that we're looking at in this, to see, can we do this and identify cancers in people with Lynch syndrome? And also, can we do this at home? So could you send off a blood test in the post, and then that would give you an idea of what's going on? And I think as the other speakers have alluded to, there's such a diversity in people with Lynch syndrome in terms of their own personal cancer risk. And this is something that may in the future be able to help tailor that. So if anyone has any thoughts, please speak to me, or you can send me an email. And so that's all from me. Thank you so much for listening.
Wonderful talk. I'm going to show you my slide of bouncers, which I've been using for years.
Oh, really?
Yeah. Great.
But I thought of that myself. I didn't steal it from you.
See?
But I guess we both go clubbing.
I've seen your pictures. I know you didn't see it from me. My pictures are better. I have some real bouncers, like a big guy called Big Malcolm on the Shark Club in Newcastle. I had to ask his permission to take his photograph. Okay. So, Glasgow, any questions for Pebs? By the way, you're not allowed to ask why she prefers to be called Pebs and what her parents called her. Okay, that is not solicible.
Penelope, by the way.
Oh, well, she divulged it now. Glasgow, have you any questions?
Anyone?
While you're thinking, I've got a question here. Yeah.
I guess my question is, do you think we're more susceptible to autoimmune if we have a upregulated or overactive immune system?
I don't think there's necessarily any evidence of that, because it's not quite in the same way. But I like the way that you're thinking about it. But I don't think so.
Thanks.
No, okay.
Mine's a bit strange.
Okay.
I've had bowel cancer and endometrial and then specified liver, which cured and whatever, and then breast cancer. But I also had a very strange T cell, which jumped somewhere, a jumping T cell. And I only found out because my daughter has Robertsonian translocation, which is an inherited thing to do with giving birth to babies. Birmingham Women's Health tested me for Robertsonian translocation, and I wasn't. I was the one, I've got it as well, although I had 4 children normally and didn't have any miscarriages. But the geneticists there rang me up late at night to tell me they were a bit concerned about this jumping T cell and they didn't know why it had happened. And I wondered if it's anything to do with Lynch or the chemotherapy. But I'm under Dr. Rangafan at haematology in Birmingham, and I go once a year now, because they don't know what it could cause, but and I haven't really looked it up too much because I don't want to know. He said it's something they've only found in the last 6 or 8 years. This jumping
T cell.
Is it?
Ever heard of that?
No.
David, world's leading authority on T cells.
I just wondered if it was something.
We will talk about you
they were very interested
on coffee. You've caught us out. None of us have ever heard of jumping T cells, but we don't think it's caused by your Lynch.
No,
because
it happened.
If anyone had discovered that, we would know. Okay. Any other questions?
Hi, John. We've got a question up.
Yes, shoot. Let's go.
Katie Boyle in Eurovision never had to run.
Thanks. I was just wondering as well if there's a link between kind of Lynch and any kind of mast cell, like activation syndrome or anything else like that. Because I've got a family history of kind of both now. Discovering, we're trying to put 2 and 2 together, but kind of make more sense.
Yeah. So, I mean, I think that we could broaden that question. Thank you to the question of the blood cancers generally, because it's a bit of a kind of uncertain area, isn't it, as to what extent they're part of this story. What's your take on that, Pebs?
I'm not sure of any particular evidence linking those sorts of things. However, as we know in congenital mismatch repair deficiency, that is characterised by more haematological malignancies. So I think it could be related, but I'm not entirely clear on the absolute numbers for that.
I mean, that's my take as well. I mean, I think you heard from Terry there is this thing called CMMID where you've inherited Lynch syndrome from both parents, and it's very rare, about 1 in a million kids get it, but then they can get blood cancers and get leukemia and so on, which means you can get blood cancer if you lose both of your copies early in life. And it may be that very occasionally in people with Lynch syndrome, they'll get a bone marrow mutation that makes them at risk of this. So it's hard to, back to the breast cancer thing, it's really hard to rule it out. And we've got slightly more lymphoma cases cropping up in our big series than we're comfortable with. So it's possible that these other tumours and the mast thing, again, you mentioned, I think you said there was a family history. I mean, it may well be that this is exposing a genetic susceptibility to other blood cancers. But as a general principle, it's not something that we screen for, because if it does happen, it's rare. And it's probably triggered by other factors in the family, I guess is the short answer. Everyone's going quiet, no one's looking at me, no one's making eye contact from the experts, suggesting that none of them want to say anything on that topic. Back with the jumping T cells, we're learning a lot. Okay, yes, please.
What makes you lose the second bouncer?
It can just happen through a sort of a random mutation. So it's.
There was a bumper sticker in America called "Shit Happens." As you go through life, you accumulate mutations in your stem cells. And so by my age, I'll have an average of about 8,000 random mutations in my DNA, just because I'm ancient. And if one of those happens to hit your one working copy of MLH1 or MSH2, and you've already not got one on the other side, then you're in trouble. So I will probably have cells in my body that have lost at least one copy of MSH2, but there's a spare copy. So it's a much rarer event to hit both in the same cell at the same time. Whereas for all of us in the room who've got Lynch syndrome, you've got 36 trillion cells with only one working copy. So the stats are higher that you'll hit the second copy by one of those accident changes. Okay?
We have
Okay.
another question in Glasgow.
Yes, shoot. I don't know why I turned around.
I think they can see your face now.
Yeah, we can see you. Sorry, this is just a quick question. It's about my father more than anything else in regards to your immune system theory. He's had bowel cancer, kidney cancer, skin cancer, Hodgkin's lymphoma, and he got cured from all those, but now he has bowel cancer again and isn't going to be treated because he's apparently too old. But my theory would be is would you be wanting to do sort of like blood test on him to find out where his immune system's sitting on the basis that his cancer has reoccurred in his bowel, and is that something that you're looking at to find out why it's reoccurring in somebody like that who's had everything previously, or am I missing a trick there?
That's a really good question.
So I guess that there's two separate things there. Obviously, your dad's gone through a lot of different cancers and lots of different treatment, presumably over the course of that. And one thing is assessing that cancer and that time and whether he's suitable for any treatment, which was obviously that they will have discussed with you.
So the question is,
Yeah, I mean, he's
would looking at his blood tell us anything new? Yeah.
They've decided he's too old for.
Shouldn't be too old.
He's too old to be treated.
We're a bit concerned about thinking he's too old to treat, but that's
Too frail.
Yeah, that's just
maybe
the
too
honest
frail.
where he is.
Yeah.
Unfortunately, it's just the way it is. They've said he's too old to be treated.
Can-
He's not. I mean, he's fit and healthy, but they just won't do anything about that.
Okay, well, maybe you could talk to some of the people in Glasgow about that management issue, but there's a
He
broader
is
question
living
you're
in
asking.
Scotland.
I think we all struggle with this. Why do some... Sorry?
He's in England.
Oh, he's in England. Okay, well, wherever your team are, put your hand up, and that's worth discussing at an individual level. But the bigger question is, how come some people get so many cancers and others get very few? And you know, I mean, it may well be that there are genetic changes in our immune system. Some of us are better at spotting these things than others. We supported the German team with our CAP samples, who showed a very important paper that if you look at the number of white T cells in the lining of the gut, the people who have a lot of them are less likely to get a bowel cancer later on. So, you know, that's suggesting that if you've got a lot of security men on duty, then that's helpful. And so that might be one of the factors. Some people have got more T cells out there ready to fight than others. And the other thing that we talked about, this CMMID, we're about to do a little study with Miranda Durkee, looking at cases where there were too many early onset cancers. I said that there was this thing that children get, right, where you've got two copies. What if you got a faulty copy from one parent and the other one just wasn't great? It wasn't actually faulty, but it wasn't as good as it could be. And we've reported a lady who got cancer in her 20s who actually had a second not very good copy. Okay, so she was a kind of in-between. She was like a severe Lynch or a mild CMMID. So we're going to try looking at some of those surprisingly early onset Lynch cases to see whether the other copy is maybe not as good as it should be. Does that make sense?
That would be very, very interesting.
So I think
that's our family.
Yeah,
where
exactly.
early
So
onset
there's a story to be told there. There's a sort of in-between stage we haven't looked at. Yeah, please.
I forgot what I wanted to ask.
That's not part of Lynch Syndrome.
It's very relevant. I had bowel cancer in 23, and since then, whenever I've had the FIT test, which I've had quite regularly because my symptoms keep changing, I've got weird stuff going on, the inflammation markers are quite high in my bowels. Is that because I've got happy T cells running around doing their job, or is that completely unrelated, and am I just screwing around with science?
So the FIT test that you've had done, they've said that it has high inflammation.
Yeah.
So the FIT test just looks for hemoglobin in the stool, and
It's for blood.
yeah, and Kevin's not here, but he's doing this big study called Fit for Lynch, trying to understand whether the FIT test is a useful adjunct in Lynch, and I think not quite sure it is. So I guess it's slightly unusual that your one is showing high markers, and it can be high for other reasons. So, for example, if you go like running, you can get a high FIT test because tiny bits of blood will come off when you're sounds very dramatic. Not that you would notice tiny bits of blood come off and you can get a positive fit test associated with that. So as long as they're following the pathway and then doing something about it or additional testing, you should, if you've had a previous diagnosis of bowel cancer, you should be having colonoscopy more frequently than you might in the screening. Yeah.
We've got.
John, your turn.
Yeah.
I just want.
Oh, gosh.
Thank you, John. I think I am a gastroenterologist, so
Another proper doctor.
I'm not so sure. Always in the sewage. Just trying to fit in. So there are two different types of stool tests that we do when patients have symptoms. One is a fit test that looks for the presence of blood, and another test, it's called fecal calprotectin, that checks for inflammation.
Is that what you had?
I had both.
Yes,
Okay, both.
and when they told you had inflammation, it's probably because the fecal calprotectin was raised. That has nothing to do with what these clever doctors are saying of an activated immune system. Sometimes, and obviously it's individual cases, because of an infection, sometimes as a result of the surgery that you had, the lining can be slightly inflamed, and that translates to this fecal calprotectin being raised. But it's basically a test that is used for the diagnosis of other diseases like inflammatory bowel disease.
Wonderful.
Great.
All right, experts, why didn't you say that?